let's get into talking about things that you care about and I care about, things that maybe have you nervous or at least, raise the hackles on the back of your neck a little bit when you hear it. And one of those things is probably, what do you do with a patient who's got a tracheostomy? I can say fairly confidently that, at least anecdotally, I think I've seen these in the pre-hospital setting dealt with not as appropriately. I've seen more of those, I think, than I probably have seen appropriately, especially when it is a disaster, when things are going south. When the tracheostomy functions fine and the patient's okay, it's no big deal. When the patient's critically ill, which is when we're kind of needed, that's when things seem to get pretty dicey in terms of the pre-hospital care that we're going to get. Dealing with a tracheostomy is not that hard. And I'm not saying that to belittle anybody, but they're not as complicated as we kind of have them built up in our minds to be. They're not as scary, but they're also, I agree, not entirely pleasant. Folks that have them usually have a bunch of other medical problems. Otherwise, they wouldn't require tracheostomy. The tracheostomy itself they're a little bit scary because, like, oh, that's his airway. That's his entire airway, even though that's not always the case. But they also get, covered in slime and gunk and stuff. They're kind of weird. They have themselves kind of a little bit of a funny smell to them. Everything about them is just kind of viscerally bad in terms of folks that if you don't deal with them real often. But remember that most of the time, the family of this person is able to take care of this all by themselves. So don't wig out too much just because you see a tracheostomy there. There's a simple kind of algorithm that we can work down to figure out what we need to do right away and how to get this person better. But the thing you got to kind of remember throughout all this is that the enemy of good when you're dealing with this tracheostomy is perfect. We don't need them to be 100%, all set. Whatever we can do to accomplish our main goal is the thing that we can kind of deal with, because these do get a little complicated. And if you go screwing with it too much, you can really get into trouble. So what is the main goal? The main goal is to get oxygen down to the alveoli so it can cross into the capillary system and oxygenate the blood, and then for CO2 to diffuse out and be ejected through the lungs and the airways. That's the main goal. And the tracheostomy is really just kind of there to facilitate that part. So whatever we can do to drive to that goal to get oxygen in and get carbon dioxide out, that's okay. It's all good if you can get that to happen, almost no matter how you do it. You don't have to have the thing functioning perfectly or the patient to be in like a perfect pre-op or post-op state. If you can get this to happen from, again, our standpoint, we can let somebody else deal with it later, take care of it later. So let's say you're called to a patient with a tracheostomy who is in respiratory distress. If they're in some other kind of distress, whatever, we don't care that much. But let's say they're in respiratory distress. You get there and their SAT is in the 70s, and they have labored breathing. Maybe they're making a lot of noise when they breathe. They indicate, they kind of moving on their chest or something like that. What's the first thing you do? Well, okay, yeah, maybe put a monitor on them, put a pulse ox probe on them, all that kind of stuff. The primary thing that I would say, our first line of defense, is to put oxygen on the patient. And it is important. Normally, we would kind of think, we say IVO2 monitor, or you show up and the first thing the paramedic student says in the scenario is like, oh, I'd put oxygen on him because he looks like he's got increased work of breathing. Okay, cool. Oxygen is still a good thing here, but don't forget that there are multiple holes that this person might be breathing through. And so put oxygen on all those holes. When you look at the anatomy, this is, if you sagittally cut somebody down the center, here's what a tracheostomy and a laryngectomy look like. If you have a tracheostomy, which is the kind of common one that we may run into in like nursing homes and stuff like that, there is still a connection, here we go, between the upper airway and the trachea. Often a tracheostomy itself, or by definition, a tracheostomy is just a hole in the trachea. So there's a hole there. There's usually a little cannula in that. But you also have space going from your mouth and your nose, generally speaking, down to the trachea itself. So you can still put oxygen up on that part. A laryngectomy is a little bit different. A laryngectomy, because you have, laryngeal cancer for other reasons. In that case, there is no connection between the mouth, the nose, and the trachea. So putting oxygen up here is not really going to do anything. It probably won't hurt, but putting it up here won't really help. But this is, you don't see these quite as often as you probably do tracheostomies, or at least do as many like transfers out of nursing homes and stuff. Laryngectomies only have a stoma. Your trachea literally jumps out the front of your body, and that's how you breathe. So in that case, don't forget that putting oxygen on not only not only the hole like down on their neck, but also their mouth and nose, if they have a tracheostomy, is super important. And that can allow the patient to breathe through their mouth and nose, because a lot of times, if they do have a tracheostomy itself, they're still able to breathe somewhat through their mouth and their nose. It just may not be super effective. So put oxygen on all the holes. Every place that the patient could get air through, put oxygen on it. That's probably the first thing that I think people forget about when we start dealing with these things. But let's say we put oxygen on him. We got oxygen everywhere. We got, 2 oxygen masks on the guy. My friend here, this little melty looking guy. I've got oxygen both over his tracheostomy and over his mouth and nose. And I'll just run that at a, non-rebreather rate. That's fine. And by the way, you can just use regular size non-rebreather mask for that. It'll work out okay. So that's our first move. Second thing we got to do, now we start dealing with the tracheostomy itself. And you ask, is the tube patent? That's the first question. Meaning, is there anything blocking the tube? Different tracheostomy setups, the tubes themselves look a little different. This one in the left upper corner is one that's got a cuff, and it's got an inner cannula, and it's got this obturator thing, which is this thing here that just kind of aids in insertion, but sometimes people forget to take out. There are some of them that have holes in them in the top, like fenestrations that the patient can kind of breathe through. There are some that don't have holes in them. There are little tiny pediatric ones, which are, I will be the first one to say, super scary. There are all kinds of different styles of tracheostomy tubes, and they function in different ways. And the way that they function is not that important for the algorithm that we're going to kind of establish here. Even it doesn't really matter what kind of tube it is per se, in terms of the stuff that I'm going to tell you to do, because it's going to be kind of universal. But let's take the typical tracheostomy tube that we usually think of. Somebody's in a nursing home or a long-term care facility, and they have a tracheostomy. A lot of times it'll look like this. So you'll find that it has, as this guy does, there's a balloon that has a cuff, just like the standard endotracheal tube does. Then there's an inner cannula, and sometimes there's that thing at the bottom again, a little obturator that fits in there that helps you insert the thing. So the first thing you have to do is ask, is the tube itself patent? And when I say the tube, I'm going to refer to just the outer part of the tracheostomy cannula, or the outer cannula of the tracheostomy itself. Is that tube patent? In order to establish that, you got to take everything off the tube. You'll find that folks sometimes have these little like caps over the end of them, depending on how they're breathing. Sometimes they'll have other things like the like heat and moisture exchangers, or they'll have these little Passy-Muir valves that allow the patient to talk with it, or again, sometimes they'll just have the thing capped. If they're in respiratory distress, the first thing you got to do is make sure that that tube is completely patent. So take all these things off the outside of it. And the second thing is to take the inner cannula out. So we've looked at him, he's in respiratory distress, we put oxygen on him, he's no better. We take any caps or anything that we find on the end of the tracheostomy tube out, and then we remove that inner cannula. It comes in 2 different parts. It has little wings. Most of them have little wings on the side of them there, and you just slide that thing out, which gives you this kind of clear inner tube. And the idea is that you can take this and clean this and get the gunk off that, and it still leaves the tube itself, the main part, the tracheostomy tube, in place. So you still, breathe through it. You don't lose your trach or anything like that. That's a fairly common thing that you can take care of at home, is have that little cannula. But in order to, again, show patency, we want to take that thing out. Don't try to suction through it. Just take it, the inner cannula out if there's an inner cannula there. Don't lose it, because you may need it again here in just a second. But take the thing out, and that leaves you, theoretically, a patent tracheostomy tube there, or at least we're going to find out if it's patent. That at least has got all the obstructions and all the stuff off of the tube itself. So we've put oxygen on the patient. We've taken everything off the tube. We've taken the inner cannula out, and Now what we're going to try to do is pass a suction catheter through the remaining outer cannula of the tube. And this can be, you could use the typical suction catheter. The size that you would officially use is 1.5 times the tracheostomy tube itself. So if it's a size 6 tube, then an 8 or a 10 French suction is what you theoretically should be using. It is often easier to use a little like red rubber suction catheter if you have those, although most EMS services probably don't have that. The idea with putting the suction catheter down through the tracheostomy tube is twofold. Yes, you can suction out some stuff. That's kind of the minor thing, though. What we're really more concerned about is showing that the tracheostomy tube is patent. So if you can pass a suction catheter down from, outside through the catheter or through the tracheostomy tube and down, an inch or two into the trachea itself, that essentially proves that the tube is patent, that there is a connection in there, and that it hasn't wiggled around, that it hasn't become clogged up, that there's not a piece of hamburger or something stuck in there. So passing the suction catheter, you can suction on the way out if you want. But the real benefit of that is proving that the tracheostomy itself, the tube, is patent. That's the goal behind that. So we've again put oxygen on the patient. They're in respiratory distress. We've taken everything off the tube. We've removed the inner cannula. We've taken a suction catheter and we've tried to pass it through the tube. And let's say it doesn't pass. The next thing you can kind of think of is there a cuff and can you deflate it? A lot of times people are not going to go home with the cuff on their tracheostomy tube up. Usually that's if you need a ventilator or you need positive pressure. A lot of times, most of the time, people will go home to their home with a tube that either doesn't have a cuff or that has the balloon down. But if it is up, you want to deflate that. And the reason for that is kind of counterintuitive a little bit. If you can't pass the catheter through there, what could have happened is that, as you see in the picture, the tracheostomy tube can kind of migrate around in the trachea and sometimes come up against the back wall. And if you take that cuff down, then that a lot of times will allow the tracheostomy tube to kind of sit back down into the trachea. And then you may be able to pass that suction catheter on top of it. So if the balloon is up, after you've tried all this stuff, if the tube doesn't seem to be patent, then try taking the cuff down and see if that doesn't seat better. And then if you're able to essentially clear that obstruction. And that happens more with as things get a little older, as your tissues kind of stretch, as the thing gets a little time to move around. You may find that they kind of, it gradually kind of works its way up so that it's now up against that back wall. That does happen from time to time. So we've taken everything off the tube and we've got oxygen on them, of course. We've removed the inner cannula from the tracheostomy setup if it is there. We've taken and we've passed a suction catheter through there, or we've tried to pass the suction catheter through there to no avail. We've deflated the cuff if it's present. Say that you were able to pass the suction catheter and it goes through the tube to prove the tube is patent, or you deflate the cuff and you've then proven that the tube is patent. What do you do at that point if the patient's still in distress? Well, you can kind of say it's probably not the tracheostomy at that point, and there's probably something else going on. So maybe he's got pneumonia, maybe he aspirated, maybe he's got pulmonary hemorrhage, maybe he's got a pneumothorax. If you are able to show that you can pass a suction catheter through there and not become obstructed that way, then what you've probably shown is that you need to do something else. And so you can look at, bagging the patient or something like that. And we'll talk about that in just a second. But say that you've tried to do that stuff and you haven't been able to get any air through, you haven't been able to pass the suction catheter, you're pretty sure that this thing is not working. Once you're pretty sure, having done these things, that the tube is not working, then what you need to do next is remove that tube and put oxygen on the patient's face and their stoma, if for some reason you haven't been doing that already. People get a little nervous about this because we're told that this is like an ET tube. This is their airway. To some extent, yeah, it is. But if this is not working, if the tube is not working just like an ET tube, then keeping it in place doesn't really help you most of the time. If the patient's in respiratory distress and this tube is occluded, or you can't pass a catheter through it, or it's just not functional, then the tube being there doesn't add anything to your patient care. So you can, with with great gusto, generally get the tube out of the way if you've been unable to clear it with any of the techniques that we've kind of talked about already. You might worry about, well, is that hole going to close up? Probably not. Once it's been a couple of weeks, these things are pretty stable, and usually you won't see a person like go home or go in a place where you might be asked to deal with a tracheostomy setup by yourself. Occasionally you might get a transfer out of like a respiratory care center or something like that, but somebody there has probably already identified kind of what the problem is, or at least what you might do about it. But even a new tracheostomy tube, if it was placed yesterday, but the patient's in distress, they're SAT 60, they're starting to get bradycardic. You can't pass despite everything you do, you can't pass a suction catheter through there. Is there a benefit to having that tube in place? Probably not. And so even if it was placed yesterday and it's still got the sutures on it, I at that point would probably say, well, we need to get that out of the way and we'll need to manage the airway in some other way. And these can go back and you can kind of redo these as well. But remember, a non-functioning tracheostomy tube, I'm spending a lot of time on it because people get hung up on this. A non-functioning tracheostomy tube doesn't offer any benefit to the person. So let's say you pull the thing out. You're then probably left with a hole. This is, this is a fairly large, old, mature stoma. The patient can usually breathe through this okay. If it was the tracheostomy tube that was the problem and you get it out of the way, a lot of times the patient can breathe through that. But think of this, if they can't, as being essentially like another mouth. Not all of them look that way, though. Not all of them are this nice big hole that you'll be able to see real well through. A lot of times they can be kind of, smaller, little pencil-looking things. If you're in, again, a little tiny kid that has a tracheostomy, then that hole may be really small. That may be the size of, like what looks like a big IV catheter, essentially. That can get kind of scary. But remember, there is a hole underneath there, most likely. And so there is some communication. Unless something terrible has happened between the outside world and the trachea, it just may be really small. So you have a patient now with a hole in their neck. You've essentially done your, not cricothyrotomy, but essentially a cricothyrotomy. Let's take it from the top. We put O2 on the patient who has a tracheostomy, who's in respiratory distress. We put it on their mouth and over top of their trachea. If you know that they have had a laryngectomy and there's no communication, then you can just put over the trachea itself. That's fine. So you put oxygen on them. We've looked at the thing and we've identified that it has an inner cannula. We take the inner cannula out. We haven't lost it because we might need it again, but we've looked at it. It doesn't appear to be particularly junky. It's not full of slime. We put it to the side. Patient still can't breathe. We attempted to pass a suction catheter down through the outer cannula of the tracheostomy tube. Been looking for this suction catheter all day. We take and we attempt to pass a suction catheter. And again, all we need to do is get a little ways in there, but we can't get the suction catheter through. It hangs up. Something happened. We take the cuff and we deflate the cuff. Try to pass the suction catheter again, see if it's patent at this point. Still not patent. Still can't get anything through. What do we do? Take the tracheostomy tube out because it's not helping at that point. It's clogged. It's just getting in the way and maybe preventing the patient from being able to breathe on their own. We remove the tracheostomy tube. Patient's monitor still looks like this. Still not great. Maybe they're getting in more respiratory distress. They still look pretty terrible. Now what? Once we got the tube out of the way, we can start doing kind of the airway management you might expect. Remember that these folks will have, in a lot of cases, probably still a connection somewhere between their mouth and their nose and their trachea, unless, again, they've had a laryngectomy where there is no connection. So just like I said, we put oxygen on their mouth, their nose, and their stoma, or their mouth, their nose, and their tracheostomy site. What we can do is start trying to ventilate from above. And you can ventilate over the stoma too, but ventilating from above, if they have a connection, ventilating through the mouth and the nose with a BVM is usually a little bit easier to do because we have equipment specifically designed for that. We have masks and stuff that specifically sits on the face, and we're familiar with how to do that. So you can just try bagging the patient from above. And this may be while your partner is, working on something down below or something like that. you may need to cover up the stoma. It's you can't see it, but if they have a hole down here and you squeeze air through it and then air just comes out that hole, what you may need to do is cover it up with some gauze, a piece of Tegaderm or something like that. You can just use a gloved hand and hold over top of that, or maybe since you're bagging with good technique and it's a 2-person technique and you really only need one hand to actually squeeze the bag, one guy grab the face, do a jaw thrust, squeeze the face mask onto the patient rather than pushing it, smashing it onto him, but to lift their face up into it. While he's got his hands there and you got one hand squeezing the backside of the bag with, again, good technique and just a couple of fingers, because we don't need to empty the whole bag into them. Maybe you can take your other hand, long way of saying it, put it over top of the stoma and just occlude it that way. And you'll be able to feel if there's air that's trying to escape around it, generally speaking. So we can try to ventilate from above, from their mouth and their nose at that point. Now, we do want to put an end-tidal CO2 detector on this if at all possible, because we put it on every airway every time. And that will show us if we are actually getting some gas exchange. If you have a good seal and you have an end-tidal CO2 sensor on here and you're not getting any waveform, nothing's coming back, then you got to think, all right, maybe there's something else that's occluding it. Maybe this isn't doing any good. If either you don't think it's doing any good or the patient doesn't seem to be getting better, you can try to ventilate the stoma itself. How might you do that? You can use just a very, a small little like pediatric baby size face mask. That will work just fine. Big ones, it's hard to get even on my big old neck here. Where's my face mask? I don't know where it went. I'm losing stuff today. You can imagine a big old mask may be hard to fit, especially in these folks that are maybe a little Pickwickian or have kind of a bullfrog neck or something like that, where you just can't get a big mask down there. But you can use a small face mask just on the end of your ET tube, or you can use what they've got here, which is an LMA, if you have that available. You could probably try to modify, you could probably try to smush an eye gel on down there on top of it, but all you're doing is just putting that on top of the tracheostomy itself and just holding it there. And it's just acting like a small inflatable face mask. But push comes to shove, just take like a pediatric or baby size mask itself and put it over top of the hole, whatever hole you may have available, and see if that works. Let's say we do that. We've tried the mouth, we've tried over top of the stoma, it's not working. My next move would probably be to put a tube in the stoma itself. Why in the stoma rather than the upper airway? Because you're there, number one, but also because there's probably a connection. There's probably a better chance of having an easy to find connection between the outside air and the trachea down on the stoma itself. That's what the stoma is there for. How might you do that? Well, you take kind of a smallish size ET tube. You're not going to want to jam a 9.5 tube down somebody's stoma usually, but whatever size the tracheostomy catheter was, if that's there, the tracheostomy cannula, you can take that and convert that to an ET tube. So if it's like a 6, put a 6.0 ET tube through the patient's neck, through that hole. You approach it just like you would if you're doing a surgical cricothyrotomy, exactly the same thing. You just passing it through the hole. Now you want to be kind of gentle about it. Sometimes this can take a little bit of force, as there can be some resistance if it's an old, like scarred up tube and or old scarred up stoma or something like that, may pose a bit of a problem. And you may have to put a little bit of force behind it, but generally speaking, you don't really want to force these things in there, because if you force things in there, you can get it to bounce off the wall of the trachea and get into the soft tissues and get into the mediastinum, and then you give them their first like 2 breaths and they go like, boop, and you're like, oh God, what did I do? You've injected a bunch of air into their mediastinum in a false tract. You want to avoid that if at all possible. So gently but assertively, take a trachea or take a standard ET tube and pass it through whatever hole is available to you there. And again, normally it's not going to be an 8.0 tube. It's going to be like a 6 or something like that. Think of it just like a cricothyrotomy and what you might do there. If that doesn't work, Either you can't get it in, or the patient's not better, you're not sure. I mean, if you got it in and you're getting a waveform back and the patient's just not getting better, then at that point, it's not having to do with the tracheostomy. It has to do with something else. But at that point, if you're not able to get the tube in, if you're unable to intubate their stoma, you can probably still intubate the tracheostomy alone. Patients who haven't had a laryngectomy, you can probably still intubate them from above. And a lot of times this is not as hard as it seems. They don't usually have tracheostomies because they have an impossible airway to get from the top. It just may be distorted. Maybe there is some kind of mass in there that prevents them from being able to be intubated otherwise. But most of the time, even if you have a tracheostomy, there's probably still a way to get the person intubated. Maybe a little difficult, but you can probably do it. You do, once you get the person intubated, need to make sure that the balloon, that the cuff goes down beyond the tracheostomy stoma itself, beyond the hole itself. And of course, if for some reason you forgot to take the tracheostomy cannula out at that point, then you're going to run into that and you need to have that out of the way too. But you can intubate these people through their mouth. And I suppose you could do a nasopharyngeal tube if you really wanted. I never really thought about it before, but I suppose you could. You can intubate these people through their mouth a lot of times, and it's not terribly, terribly difficult. It's usually easier than you think. Prepare for worse, but know that you'll probably be able to get it if you're a good, solid intubator otherwise in a lot of these cases. All right, makes sense so far? Talk about laryngectomies real quick, because I've been saying mostly tracheostomy, and I have in my mind the tracheostomy stuff where there's a cannula in place and there's an inner cannula, and the person's been chilling out at their house for a while because of their hypoventilation syndrome or something like that. Or maybe they're at, a respiratory care center or a long-term care center where they're on a vent all the time, or maybe it's a home vent and somebody's just been managing it. They're the laryngectomy folks, the folks that have had their larynx, the connection between their oropharynx and their upper airway severed and don't have that connection anymore. That's the laryngectomy folks. All the stuff I kind of talked about so far kind of holds true mostly for these laryngectomy folks as well. A lot of times, rather than having like a small tracheostomy tube, they'll have a Lary tube, i.e. Laryngectomy tube, which is usually a little bit bigger and a little bit softer than the tracheostomy tube that you may kind of see. Sometimes folks will have their tracheostomy capped as well, or their laryngectomy stoma capped as well. They may have a speaking valve on it or essentially a cap over it, and then they've got this other little thing back here that kind of allows them to phonate a little bit, but you could think of it as a valve that lets you speak. The long story short is it may look a little bit different externally. You may look at it and say, like, that's not this thing that the Walt showed me. Can I treat it the same way? More or less, yes. More or less, you treat these kind of the same way. First thing you do is try to get any obstruction off of the stoma or off of whatever tube might be there. So you remove caps, you take out any valves or anything like that. Usually they just kind of pull off. Sometimes it's a little bit of a twist with it. The biggest thing to kind of remember is that as we're doing the rest of this stuff, you don't really have the option of eventually ventilating or intubating from the mouth. Whatever hole is here is what the patient has to deal with. So you can kind of focus your efforts there. And otherwise, most of this stuff is pretty much the same, even if they've had a laryngectomy. So you take everything off the tube or off the stoma if that's all that's kind of left there. If there's an inner cannula, you would take the inner cannula out. You'd try to pass a suction catheter through the tube if there was a tube still in place. If there was a cuff for some reason, you would take the cuff down if you're not able to pass that suction catheter and if things are still not getting better. And then eventually, same thing, you would remove the tube. So these are fairly standard. Again, you don't have to necessarily know their anatomy to be able to figure this part out. It sort of makes sense, hopefully. You clear the tube out. You try to take the inner part, and again, this is all about just clearing the tube. You try to pass the suction catheter to prove patency. You take the cuff down, and then if none of the stuff works and you can't get a suction catheter through at that point, you take the tube out. Again, the only real difference would normally be that before I would say, if that hasn't worked, start ventilating the mouth as you got oxygen over top of the stoma or over top of the hole, over top of the neck. we said before, start trying to ventilate the mouth because we're used to doing that and our equipment's designed for that. And if that doesn't work, try to ventilate the stoma. If that doesn't work, then you can try to intubate the stoma. Cool little animation, huh? And if that doesn't work, you can try to intubate the mouth. This is, again, the tracheostomy patient. I'm going back and reviewing that stuff. To take a step towards the laryngectomy patient, we can basically just kind of take out 2 of those steps. So if we know they've got a laryngectomy and no connection between their mouth and their mouth and their trachea, essentially, or their pharynx and their trachea, get it out here, then we can go ahead and just try ventilating the stoma pretty much off the bat, because there's no connection, there's no meaningful passage up there that will be able to pass air through and get it down into the lungs. If that doesn't work, you can go straight to intubating the stoma itself. And if none of that stuff works, or if you can get it in, but the patient's still in distress, again, you got to think about other stuff. Does he have a pneumothorax? Is he just really gunked up down there? Does he have a pneumonia? All that other kind of stuff. And you can treat him at that point just as if anybody else with a standard airway. To review one more time, I keep saying it, but I think it really helps to go through these steps. So we have a patient in respiratory distress. They have a tracheostomy. Maybe they've had a laryngectomy. We don't know. There's some sort of tube in their neck that they seem to be breathing through. Put oxygen on the face and over the tracheostomy while you're getting stuff together. First step, take the tube, take everything off the tube, pull off any valves or anything like that, and then remove the inner cannula, look at it, don't lose it, but kind of put it off to the side. Take a suction catheter. Here we go. By the way, if the patient is, when you take that inner cannula out, if patient is fixed, okay, that's okay. You don't actually have to do anything else. Is patient fixed? Cool. Hold on to this little sucker for a second, because there's a really important part that I didn't mention so far. That's okay at that moment. If he's not fixed, take a suction catheter, try to pass it through the tracheostomy tube. If you pass the suction catheter through the tracheostomy tube and it goes down, that far into the patient, essentially like the grip of your hand, if you can get it that far into the tube, then you've more or less shown that the tracheostomy tube is patent and that you can use it for something like ventilating the patient. If you can't pass the catheter through it, then deflate a cuff if there's a cuff there. See if it moves, a little bit more and gets off the back wall of the trachea, and then try to pass that suction catheter again. If the suction catheter still doesn't pass at that point, then the tube is not functional. It's either in the soft tissues, it's got an occlusion, it's got some reason that it's not working, but it's not helping right now. And we just need to get it. It's an obstruction in the airway. Let's get it out of the way. And you just pull that out. They're kind of hooky shaped, but you just kind of rock them out like that. They get a little bit of like resistance, but you're probably not going to like rip the patient's neck off or something like that. You can just kind of give it a shove, give it a pull. What I didn't mention before, and I probably should have, was, okay, we take the inner cannula out, we take the suction catheter and we pass it and it goes through, and we can pass it all day long if we want. We can, again, try to suction on the way out and all that kind of stuff. But say the patient doesn't get better, but we've got a patent tracheostomy tube. What's some stuff you might consider? Well, we can consider putting more oxygen on it if we don't have oxygen on it and all that kind of stuff. But a lot of times we're going to be thinking, I need to bag through this, especially if the patient's in cardiac arrest. And you look at it and you're like, I want to be able to bag that patient. You take your bag and you stick it on there, but it's not working. There's nothing to connect up to. This hole is the same size as this hole, and they don't marry up. There's no male-female component to it. They're not having a good time. They're just kind of banging against each other. What do I do at that point? This happens all the time, by the way. I've seen at least 2 or 3 cases where somebody has essentially had a bad outcome because this wasn't really recognized. What do you do when you can't get that to work, but you want to be able to bag through a tracheostomy cannula? The problem usually, it's not that these won't work for it. The problem usually is that the inner cannula is the thing, too many things, that has the hub on it. So the inner cannula is the thing that usually connects up to the bag. So you have, that's why I said before, when you take this out, don't like throw it across the room. Don't give it to somebody else to hold on to who's not super reliable. Because if you want to bag the patient, eventually you're going to have to stick that inner cannula back on there or get something that has an inner cannula like that. And then you can connect it up. Sorry, everybody out there, you just got, you got bumped. All right, so really important point, inner cannula often required. If it has an inner cannula, it is essentially going to be required to be able to bag the patient. If you have lost the inner cannula, the patient has lost the inner cannula and they need to be bagged, then what you need to do is switch it out for an ET tube. All right. So we did all this stuff. We've got the tube out of the way. When you have the tube out of the way, now we just start to do basic airway management. You can kind of pick which one you want to do first. You can bag from above or bag from the stoma, but probably BVM from above and see if you can occlude the stoma. And if that works, then hey, we're familiar with it and it's going great. You can BVM through the stoma. And again, hey, if that works, okay, just keep doing that for now and transport them if at all possible. If they're an hour and a half away, that may be a little bit of a more difficult proposition. So you may need to intubate the stoma. And how do you do that? Tubes out of the way, you take a small ET tube, pass it through. You only have to pass it in just enough that the cuff is, past the hole itself and into the trachea. It shouldn't go 27 centimeters down into the patient's lungs because their carina is literally right there. It's only a couple of inches. And if you can't intubate their stoma, you can intubate their mouth. Cool, makes sense? Hopefully it does. It's not all that complicated. I find myself, again, repeating a lot of times, but what you're really doing is, number one, making sure that the tube itself, and we're talking about the outer tube, is patent, proving that it's patent by passing a suction catheter. And if that doesn't work, either getting it out of the way or reattaching whatever inner cannula might be there or whatever, adapter is needed to bag through, and then bagging through that. If it has, oh, by the way, one last thing, if they have a cuff and you decide you want to bag through their tracheostomy tube and you've got the inner cannula back on, you probably need to put the cuff back up and then it functions essentially just like an ET tube. Don't forget that part there. It'll still kind of work, most likely even if you don't put the cuff up. But if you need like good pressures or PEEP or something like that, you need the cuff up to do it. Lots of stuff to talk about, but really once you understand them a little bit, not terribly complicated. Hopefully that gives you a little bit of an algorithm to go through. Again, one more time, take everything off the tube, remove the inner cannula, try to pass the suction catheter. If it doesn't pass, try to deflate the cuff if there's a cuff present. And if you can't get anything to pass through the tube itself, then get the tube out of the way and start bagging their face, start bagging their stoma, put something through the stoma, put a tube through their face. Those are the steps for it. Again, our website, emsgrandrounds.org. That'll have the link to the CE certificate and stuff like that. And again, that won't be up till after the presentations are done. So don't go looking for it now. It ain't going to be there. But emsgrandrounds.org, go to the view us live and get credit link, and it'll all be there. Probably around noonish, I think, if that's all ends on time. Okay, well, that'll do it for this first session here, and none too soon either. You're probably tired of me talking. I talked a lot more about it, but again, I've had a couple of cases of these relatively recently where I thought like, okay, this is really not as clear for folks as it is, as it absolutely has to be, because they are reliant on these tubes. And if you don't really know what you're doing with them, then you're not going to know how to fix the person when they really, 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 really need you. And the steps to fix it are fairly simple. So remember that stuff, be aggressive on that stuff. A tube that is not patent, a tube you can't pass a suction catheter through is not working, and get it out of the way, and that's okay. We will be back in 5